Welcome to Deep Dive Ortho. Today we're plunging into a condition that profoundly impacts hand and upper limb function, often challenging both diagnosis and management, Raynaud's phenomenon. This deep dive will explore how this condition affects daily life, its crucial clinical distinctions, and the latest in assessment and management for you, the medical professionals listening. Our mission today is really to uncover insights vital for enhancing patient outcomes, equipping you with knowledge that truly makes a difference in your practice.
Thank you. Raynaud's phenomenon, or RP as we'll often call it, is indeed far more than just, getting cold hands. It's a transient peripheral vasospastic response that profoundly impacts patients, often without clearly standardized management guidelines. Understanding its nuances is absolutely crucial for any clinician, especially those involved in orthopedic and musculoskeletal care, as its functional impact can be quite significant.
Professor, we hear the term Raynaud's quite a bit, but for many clinicians, perhaps especially those outside of rheumatology or vascular medicine, the full picture of an attack might not be crystal clear. Could you really paint that picture for us? What's actually happening in the body during one of these episodes?
Certainly. RP is characterized by these acute, short-lived decreases in blood flow, primarily affecting the fingers and toes. That's what most people think of. However, it can occasionally extend to other extremities, the ears, the nose, even the tongue or nipples sometimes. Now, these attacks, they're typically triggered by exposure to cold. And that doesn't have to be extreme cold. Even a slight drop in temperature, like reaching into a freezer cabinet or just being in an air-conditioned room, can set it off. Or emotional stress is another big trigger. The hallmark of an attack is what we call the classic triphasic color change. It's quite dramatic to see. Imagine the sequence. Initially, the affected digits turn stark white, really pale.
That's the vasospasm kicking in.
Exactly. Profound vasospasm and ischemia, where the small blood vessels narrow so much that blood flow is severely restricted. Following this, they often turn blue. That's cyanosis, which results from the deoxygenation of the blood that's sort of trapped in the veins. And finally, as the spasm eases and blood flow rushes back in, the digits turn red. That's called rubor, indicating hyperemia.
So white, then blue, then red. That's the classic pattern.
That's the classic pattern, yes. But it's important to stress, really important, that while the triphasic change is classic, the initial blanching, that turning white, that must always be present for a diagnosis of RP.
Ah, okay. So you don't always get the blue and red phases.
Precisely. Cyanosis and rubor may not always occur, or might be less distinct, but the initial blanching is the critical diagnostic feature. And these attacks typically last somewhere between 10 and 20 minutes, usually. For the patient, it's not just a visual thing. It's often accompanied by numbness, tingling, maybe a pins and needles feeling, or even a deep, aching pain as the blood flow is cut off and then returns. It can be quite debilitating in the moment.
So what does this all mean for patient presentation when they come into the clinic? How common is RP, and what are the key distinctions clinicians really need to have in mind when they see these symptoms?
That's a crucial point, and it leads us straight to the fundamental classification of RP, which is absolutely essential for guiding our management approach. We differentiate between primary Raynaud's phenomenon, or PRP, and secondary Raynaud's phenomenon, SRP.
Right. Primary and secondary.
Yes. PRP is idiopathic. That just means it has no known underlying cause that we can pinpoint. This form accounts for the vast majority, roughly 80% of all cases. So it's by far the more common presentation you'll encounter. Clinically, it's usually milder. The attacks tend to be symmetrical, affecting both hands similarly, and it often, though not always, spares the thumbs. That could be a useful clue.
And it starts earlier in life, you said.
Typically, yes. Often begins in an individual's teens or 20s, and we frequently see a family link, suggesting some genetic predisposition. What's particularly interesting about PRP, and maybe often overlooked, is that it can also show up as an exaggerated vasodilatory response to warmth, alcohol, or even spicy food.
Oh, really? So not just constricting in the cold.
Exactly. It's not just about cold hands. It can involve flushing of the face and chest wall. It points perhaps to a broader issue with thermoregulation, a kind of hypersensitivity of the vascular system. Now, in stark contrast, secondary RP, SRP, is associated with an underlying disease or condition.
Okay, so there's something else driving it.
Precisely. These are most commonly autoimmune diseases and connective tissue disorders. Systemic scleroderma is perhaps the most prominent example. RP occurs in up to 90% of those patients, often as one of the very first symptoms they notice. We also see it in a significant number of patients with other conditions. Maybe 10–45% of people with lupus, about a third with Sjogren syndrome, 20% with dermatomyositis or polymyositis.
So a strong link to rheumatological conditions.
Very strong. But SRP isn't just about autoimmune links. It can also be associated with occupational exposures, like hand-arm vibration syndrome, HAVS, from using vibrating tools for long periods. Certain medications can trigger or worsen it too, things like beta blockers, some migraine medicines. Even conditions that compromise blood flow or nerve function locally, like carpal tunnel syndrome, where pressure on the median nerve might exacerbate symptoms, could potentially be linked.
And clinically, secondary RP is usually more severe.
Much more severe, generally. Symptoms typically appear later in life, often around age 40, which helps distinguish it from the earlier onset of PRP. And crucially, unlike PRP, SRP can lead to what we call trophic changes. These are clear signs of poor tissue nutrition due to chronic, repeated ischemia.
Trophic changes, what does that look like specifically?
Well, you might see changes in the nails, small pits or indentations on the fingertips, painful cracks or hacks in the skin, or, most alarmingly, digital ulcers, open sores. In its most severe forms, prolonged, unmanaged SRP can even result in gangrene or the loss of digits.
Wow, so that's a critical difference.
It's a critical clinical distinction. Trophic changes are never seen in primary RP. If you see any digital ulcers, that should immediately raise a big red flag for secondary Raynaud's and mandates a thorough investigation for an underlying systemic condition.
That makes the distinction incredibly clear. It sounds like the impact on a patient's daily life must be truly considerable, extending far beyond the immediate discomfort of an attack. What kind of disability do we typically see with RP, and how does it manifest in terms of their functional capabilities?
That's a really powerful point, and it's where the condition truly hits quality of life. Patients consistently report a significant loss of hand function, considerable distress, and a reduced overall quality of life. The data we have really underscores this. Something like 87% of SRP patients and 71% of PRP patients report having to significantly alter their daily routines because of their condition.
That's huge. Just simple daily tasks must become challenging.
Exactly. Imagine the implications for simple things like buttoning clothes, opening jars, using a keyboard, let alone hobbies or work tasks. A recent, quite illuminating study highlighted this impact. It showed that participants with Raynaud's experienced more disability across all subscales of the Quick-Gauge questionnaire, that's the shortened disabilities of the arm, shoulder, and hand questionnaire, compared to healthy controls. So this isn't merely about experiencing pain or the color changes. It directly affects their ability to perform everyday activities, their capacity to work, or their participation in sports and arts.
And did that study differentiate between primary and secondary RP?
It did, yes. It involved 57 participants split into PRP, SRP, and healthy control groups, and it found that, as a whole, the RP patients showed statistically significant higher upper limb disability compared to controls. But importantly, when comparing the two RP types, the SRP group exhibited significantly higher disability scores overall on the Q-H, and specifically on the work and sports arts subscales compared to the PRP group.
Which makes sense given the potential for tissue damage in SRP.
It does. It really underscores the greater severity and functional limitation associated with the secondary forms. But here's a key takeaway from this research, especially for our listeners in orthopedics and rehabilitation. The disability experienced by RP patients seems to be more strongly linked with impaired hand mobility and strength, so reduced range of motion and grip capabilities, than with the severity of the vascular alterations themselves.
That's fascinating. So it's not just about how bad the blood flow gets, but how well the hand can actually move and grip.
Precisely. It's a profound shift in perspective, really.
Yeah.
It suggests that even if the vascular changes are quite pronounced, a patient's functional limitations might be more closely tied to the physical capacity of their hand. And this, opens up entirely new avenues for targeted therapeutic and rehabilitative interventions. We need to think beyond just the drugs that manage blood flow.
So now that we've truly grasped the significant impact Raynaud's has on daily life, the critical next step for any clinician is accurate diagnosis and assessment. Professor, how do we go about distinguishing between primary and secondary forms, and what should our listeners be looking for when a patient presents with these symptoms?
Right, diagnosis. It starts, as always, with a really meticulous patient history and a thorough physical examination. Clinicians should pay close attention to the age of onset.
Yeah.
As we said earlier, onset, teens or 20s, strongly suggests primary RP. Onset in the 30s or 40s, that should immediately raise suspicion for secondary RP and prompts you to think about underlying connective tissue disorders.
What else in the history is key?
Well, you need to ask about the specific location of affected areas. Is the thumb involved? Remember, PRP often spares the thumb. Ask about symmetry. Are both hands affected similarly? And critically, Ask directly about the presence of any digital ulcerations or sores. Have they ever had sores on their fingertips that were slow to heal? You also need to get a handle on the severity and frequency of attacks. How often does it happen? What brings it on? Cold, stress, something else? Asking, when was your last attack, can be helpful.
And looking for clues about underlying systemic conditions.
Absolutely vital.
Yeah.
You need to probe for systemic symptoms. Things like photosensitivity, does their skin react unusually to sunlight, persistent mouth ulcers, any skin tightening, especially on the hands or face, dry eyes or dry mouth, suggesting Zika symptoms or perhaps Sjogren's. These are all red flags for associated autoimmune conditions.
And on examination, assuming they're not having an attack right there in the clinic.
Yes, observing the color changes during an attack is incredibly valuable, but often challenging. So encouraging patients to take photos or videos on their phone during an episode can be immensely helpful. Show me what it looks like when it happens. You should always check peripheral pulses, radial and ulnar, just to help exclude any underlying large vessel disease, which can sometimes mimic RP. And critically, you must actively look for those trophic changes we discussed. Signs of poor tissue nutrition, subtle nail changes, any digital pitting, those small indentations on the fingertips, painful hacks or fissures in the skin, or, most significantly, digital ulcers.
And just to reiterate that point,
Digital ulcers are never seen in primary RP. Their presence is a strong indicator of secondary RP and demands immediate further investigation. Sometimes you might see levator reticularis during an attack, that purplish mottled skin pattern, but you need to differentiate that from fixed patterns seen in other conditions.
beyond that comprehensive clinical picture, Professor, what specific diagnostic tools and objective measures can we use, both to evaluate the vascular side and that functional impairment we talked about?
Yes, the objective assessment. This gives us concrete, measurable data beyond just what the patient tells us, which is crucial for confirming the diagnosis and tracking progress over time. For the vascular side, we use several non-invasive techniques. A handheld infrared thermographic scanner is an excellent tool. We use it to precisely measure temperature changes.
How does that work in practice?
Well, you get a baseline temperature after the patient has acclimatized to a warm room. Then you perform a cold stress test, or CST. Typically, this involves immersing both hands for about 2 minutes in cool water, say around 10 degrees Celsius. Then you measure the temperature immediately after and at regular intervals as the hand rewarms. A delayed or incomplete temperature recovery clearly indicates vascular dysfunction. The study we mentioned earlier found some interesting things here. RP participants, especially those with PRP, consistently had significantly lower hand temperatures both before and after the cold stress test compared to healthy controls.
Suggesting a generally lower baseline and poorer recovery.
Exactly. They also showed decreased blood flow in the radial artery, which we assess using a bidirectional vascular Doppler compared to controls. Interestingly, there weren't significant differences in ulnar artery blood flow or oxygen saturation between the RP groups and controls in that study, suggesting maybe some distinct patterns of vascular impact.
And you mentioned oxygen saturation in Doppler.
Yes, a simple finger pulse oximeter gives us a quick measure of peripheral oxygen saturation, SEPO2. And the bidirectional vascular Doppler, as I said, assesses blood flow velocity in the radial and ulnar arteries at the wrist. We usually take a few measurements and average them for reliability. These tools help us quantify the physiological changes.
Okay, so that covers the vascular assessment. What about measuring functionality objectively?
For functionality, the Quick Dayash questionnaire is a really well-validated standard tool. It's self-administered and assesses the patient's perceived disability across daily activities, work, and sports or arts. Scores range from 0, no disability, up to 100, severe disability. But to objectively measure physical limitation, range of motion, or ROM is critically assessed. We use a simple stainless steel finger goniometer to evaluate active and passive flexion and extension of key joints, typically the MCP, PIP, and DIP joints of the index finger, and the IP and MCP joints of the thumb.
Measuring how far the joints can move.
Precisely. We usually take 3 measurements for each movement and use the average. It's a highly reliable way to quantify joint movement. Then there's pinch strength. We assess both tip-to-tip pinch and lateral pinch using a mechanical finger dynamometer or pinch gauge following a standardized protocol.
And did the research link these functional measures to the disability scores?
Yes, very clearly. The study specifically highlighted that RP patients, compared to healthy controls, showed objectively decreased ranges of motion, particularly passive extension of the index finger and active flexion and extension of the thumb. And importantly, the analysis showed that these functional parameters, index finger flexion and extension, thumb flexion and extension, and lateral pinch strength, were statistically associated with the overall upper limb disability reported on the quick day.
So reduced movement and strength directly correlated with higher perceived disability.
Exactly. Lower oxygen saturation and lower temperature after the cold stress test were also linked specifically to higher work disability scores. And the multivariate analysis really hammered this home. Index finger extension, lateral pinch strength, and oxygen saturation were significantly associated with disability in RP patients.
What does that mean in practical terms?
Well, what this complex data really distills down to is this. These factors, hand movement, grip strength, and oxygen levels, collectively accounted for over half of the total variance in upper limb disability, about a quarter in sports arts disability, and nearly half in work disability. It tells us that if we can improve a patient's hand movement, their grip strength, and perhaps their oxygenation during attacks, we're directly addressing the biggest drivers of their disability. That's where rehabilitation efforts can make a huge difference.
That clarity on objective measures is incredibly valuable for our listeners. So, beyond the clinical assessment and these functional and vascular tools, what about blood tests? What laboratory tests complement this assessment to confirm or rule out those underlying systemic conditions, especially when you suspect secondary RP?
Right, when there's any suspicion of secondary RP based on the history or exam findings like ulcers or later onset, a comprehensive panel of blood tests becomes essential. Anti-nuclear antibody, the ANA titer, is critical here. A positive result often indicates an autoimmune reaction, a hallmark of many connective tissue diseases.
And if the ANA is positive,
Then an ENA screen that's extractable nuclear antigen can help identify specific antibodies linked to distinct conditions. For example, anti-topoisomerase antibodies might point towards diffuse systemic sclerosis, anti-centromere towards limited systemic sclerosis. Anti-Rho or anti-lock antibodies can suggest Sjogren's, and a positive anti-DNA titer is highly suggestive of lupus. These help narrow down the possibilities. A full blood count is always useful, just as a general screen. And ESR erythrocyte sedimentation rate, or CRP, C-reactive protein, are important markers for systemic inflammation.
but a normal CRP doesn't rule out connective tissue disease.
That's a key point. Elevated levels can certainly support a diagnosis, but a normal CRP doesn't definitively exclude an underlying connective tissue disease. Clinical suspicion remains paramount. We should also always check thyroid function, as hypothyroidism can cause cold fingers, which might mimic or worsen RP, and it's easily treated.
Okay. And you mentioned nail fold capillaroscopy earlier.
Yes, nail fold capillaroscopy. This is a highly sensitive and non-invasive technique that's truly invaluable for detecting early connective tissue disease, sometimes even before overt clinical symptoms appear. It involves examining the tiny capillaries at the base of the nail fold, usually with a dermatoscope or a specialized capillaroscope.
What are you looking for there?
We're looking for subtle microvascular changes, things like enlarged or dilated capillaries, areas where capillary loops have dropped out or disappeared, or tiny hemorrhages from leaky vessels. While it's not typically done in primary care, it requires specific equipment and expertise. Early referral to a specialist who performs capillaroscopy is strongly recommended when you suspect secondary RP. Abnormal capillary patterns, particularly those scleroderma-like patterns, are powerful predictors of developing a connective tissue disease, sometimes years before a full diagnosis is made.
And the guidelines support this.
Yes, the European Society for Vascular Medicine, ESVM guidelines specifically recommend these blood tests, ANA, ENA if needed, ESRCRP, thyroid function, and capillaroscopy where available. They give it a grade Psi-IL level C recommendation, highlighting its importance in the thorough workup for suspected SRP.
Okay, so we've covered the nuances of diagnosis quite thoroughly. Now let's turn our attention to management. Professor, once Raynaud's phenomenon is diagnosed, what are the primary goals of management, and what non-pharmacological strategies should clinicians advise their patients to adopt first? This is where our listeners can really start making a difference day to day.
Absolutely. The overarching goals of managing RP are multifaceted. We aim to reduce the frequency and severity of attacks, obviously. We want to prevent irreversible tissue damage that's particularly crucial in secondary RP. We need to preserve essential hand function. And perhaps most importantly, we need to significantly improve the patient's overall quality of life. For milder cases, or really as a foundational approach for all patients, regardless of severity, lifestyle modifications are paramount. This isn't just a casual suggestion. It carries that grade 3A level C recommendation from the ESVM guidelines.
So what does that involve specifically, beyond just keep warm?
It involves rigorous cold avoidance. Educating patients on dressing warmly in layers is key. Emphasize that mittens are generally warmer than gloves because they keep the fingers together, sharing
Good
warmth.
tip.
Encourage them to use heated mittens or socks, especially if they're outdoors in the cold, and even just wearing socks indoors in cooler environments can help. Advise them to avoid sudden temperature changes reaching into freezers without protection, stepping into blast air conditioning without a jumper. Also, avoiding triggers like smoking is absolutely crucial. Nicotine is a potent vasoconstrictor and can cause permanent vascular damage over time, making RP much worse.
What about exercise and stress?
Regular exercise is generally beneficial for circulation, but it should be done in a warm environment to avoid triggering an attack during the activity itself. Patients should also learn simple measures to use during an attack to help restore blood flow, things like vigorously wiggling their fingers, swinging their arms in wide circles, the windmill technique, or placing their hands under their armpits or in warm, not hot, water. Good skincare is also essential. Using a good emollient lotion regularly helps prevent dry or cracked skin, which can be a portal for infection, especially if they are prone to trophic changes. And stress management techniques, mindfulness, deep breathing, biofeedback are incredibly important, as emotional stress is a significant and often underestimated trigger for many people. Finally, for those with work-related RP like HAVS, avoiding or minimizing exposure to vibrating tools is obviously key.
That's a really comprehensive approach to lifestyle. But, Professor, when those crucial general measures just aren't enough to control the symptoms and it's really impacting their life, what's the next step? What's the pharmacological pathway?
Right, this is where we move to medication. For patients whose symptoms significantly interfere with daily life, despite trying those general measures. The dihydropyridine calcium channel blockers, or DHP-CCBs, drugs like nifedipine or amlodipine, are unequivocally the recommended first-line drug treatment. This carries a strong ESVM grade I level A recommendation, meaning there's robust evidence for their benefit in reducing attack frequency and severity.
And you mentioned slow-release preparations are preferred?
Generally, yes. Slow-release formulations are preferred to try and minimize those dose-related vasodilatory side effects, which can be quite bothersome. Common side effects include peripheral edema, ankle swelling as typical palpitations, sometimes a reflex tachycardia where the heart speeds up, dizziness, and headaches. Headaches are very common initially, often a sign the drug is working, and they tend to subside over a few weeks as the body adjusts.
How do you typically start these medications?
We advise starting at a low dose. For example, nifedipine retard might be started at 10 mg 2 or 3 times daily, or amlodipine at 5 mg daily, perhaps going up to 20 mg daily eventually. You titrate upwards gradually over several weeks, balancing symptom control against tolerability. It's really important to encourage patients to persevere with initial side effects for a few weeks if possible, as they often diminish. Of course, you need to be mindful of contraindications, things like hypotension, severe aortic stenosis, hypertrophic cardiomyopathy, severe pulmonary hypertension, and generally CCB should be avoided in pregnancy unless there's active digital ischemia due to potential risks.
What if the calcium channel blockers don't work well enough or the side effects are intolerable?
Good question. For patients who don't respond adequately or only partially, phosphodiesterase inhibitors, PDE inhibitors like sildenafil, can be added to the CCB therapy, or used as monotherapy if the CCB didn't work at all or wasn't tolerated. Sildenafil is typically started at a low dose, maybe 20 milligrams once daily, and then carefully titrated up, perhaps to 20 milligrams 3 times a day, over 4 to 6 weeks, again based on response and tolerability.
Are there other options beyond sildenafil?
Yes, if these first and second line options fail or aren't tolerated, there are other things to consider. Topical nitrates, like a 2% nitroglycerin ointment applied locally to the affected digits, can sometimes help. But you have to watch for systemic absorption, causing hypotension or headache. Angiotensin receptor antagonists, like losartan, have shown some benefit. Even certain antidepressants, specifically fluoxetine and SSRI, have been used, possibly due to effects on serotonin pathways involved in vasoconstriction. The choice really depends on the individual patient, their comorbidities, and what they can tolerate.
It's clear there's a definite progression in pharmacological management. But what about the most severe cases, particularly those patients presenting with digital ulceration? And in such situations, Professor, what role, if any, does surgery play?
Yes, for severe cases, especially where there's active tissue ischemia or digital ulceration has developed, the management really escalates. Intravenous infusions of prostaglandins, such as alloprost, are often used in these situations. These are potent vasodilators, but also act as platelet aggregation inhibitors, helping to improve blood flow and prevent microclots, which is critical for healing ulcers and preventing further tissue damage. For recurrent digital ulceration, particularly in conditions like systemic sclerosis, bosentan, which is an endothelin-1 receptor antagonist, might be used specifically for prevention of new ulcers, though it doesn't typically heal existing ones. Low-dose aspirin, maybe 81 mg daily, is generally recommended for secondary RP patients who have a history of ischemic ulceration, just to reduce the risk of further thrombotic events. If they can't tolerate aspirin, clopidogrel or dipyridamole are alternatives.
Okay, that covers the advanced medical management. What about surgery? Is there a place for it?
In terms of surgery, for primary RP, there's generally no role. The ESVM gives us a grade I level C recommendation, meaning any benefit is less well established and the risks often outweigh potential gains. However, for complicated secondary RP with severe digital ulceration or even gangrene, surgical debridement, carefully removing the dead tissue, can significantly improve symptoms and help healing by creating a clean wound bed. While there isn't strong RCT evidence, extensive clinical experience supports its use for painful, non-healing ulcers.
What about procedures like sympathectomy?
Localized digital sympathectomy, where the sympathetic nerves around the affected digital arteries are stripped, may have a role in very severe refractory cases that haven't responded to maximum medical therapy. The aim is to interrupt those vasoconstrictive nerve signals locally. However, the long-term effectiveness is still debated and requires more research. Studies show variable success, and symptoms can recur over time. It's important to note that broader upper limb sympathectomy or cervical thoracic sympathectomy, those bigger operations are largely no longer recommended. Studies haven't shown significant or sustained benefit. Improvements are often short-lived, and there can even be late worsening of symptoms.
And arterial reconstruction.
Techniques like venous grafts, arterial grafts, or balloon angioplasty, while they sound appealing for specific blockages, also lack robust RCT evidence to support their general use in RP. They remain highly specialized procedures for very specific, complicated cases, perhaps where larger vessel occlusion is involved. Amputation, sadly, remains a last resort. It's only considered for severe, intractable pain or for refractory infection, like osteomyelitis, when absolutely everything else has failed to save the digit or alleviate the suffering.
That's a comprehensive overview of current management strategies. Looking ahead, Professor, what promising developments are on the horizon for understanding and treating Raynaud's phenomenon? And how does interprofessional collaboration fit into this evolving picture? This is where we start to see the future, perhaps.
That's an excellent question, and it's where we see some really exciting advancements emerging, particularly in understanding the underlying causes. Recent, quite groundbreaking research from Queen Mary University of London and the Berlin Institute of Health has identified specific genetic factors linked to Raynaud's phenomenon.
Genetic causes. That sounds like a big step.
It's a monumental step, really, because it could pave the way for the first truly effective, targeted treatments, moving beyond just repurposing drugs developed for other conditions, which often come with significant side effects for RP patients. The study notably identified a variant in the ADRA2A gene. This gene is known to be involved in blood vessel constriction via adrenaline pathways.
So a direct molecular target.
Exactly. This discovery provides a specific target for future drug development. Interestingly, the researchers even suggested that certain existing drugs, like the antidepressant mirtazapine, which happens to inhibit ADRA2A, might offer an alternative therapeutic avenue for RP, potentially with fewer off-target side effects. That needs testing, of course. Furthermore, this genetic study unearthed another intriguing link. A genetic predisposition to low blood sugar hypoglycemia was associated with an increased risk of Raynaud's.
Low blood sugar, how might that be connected?
The mechanism isn't fully clear yet, but it suggests a potential new lifestyle recommendation for patients to consider, namely, avoiding prolonged episodes of low blood sugar. Perhaps counseling on dietary adjustments to maintain stable glucose levels could become part of management in the future. These findings are foundational, offering tantalizing glimpses into the disease mechanisms. The next crucial steps are validating these links in diverse populations and through rigorous functional studies to confirm causality and test potential new interventions in clinical trials. It's a long road, but it's exciting.
That genetic research sounds incredibly promising for more personalized approaches down the line. But thinking about today's practice, Professor, how can the medical community leverage our current evolving understanding to enhance patient care right now, especially through that multidisciplinary lens you mentioned?
That's the key question for clinicians listening now. Translating genetic insights takes time, as you say. But enhancing care today relies heavily on applying our current knowledge collaboratively. Effective management of Raynaud's truly thrives on an interprofessional approach. No single specialty has all the answers for a condition with such diverse impacts.
Can you break down how that team works?
Certainly. Think of the network. The primary care physician or GP is crucial. Often the first point of contact, vital for initial diagnosis, managing straightforward primary RP, and critically, recognizing red flags and referring appropriately when secondary RP is suspected. That referral pathway is guideline recommended. Rheumatologists are essential for diagnosing and managing the underlying autoimmune diseases in SRP, guiding systemic therapies. Vascular surgeons or specialists step in for severe cases, complex ulcers, or considering interventions. Nurses, especially specialist nurses, are vital for patient education. Trigger avoidance, proper insulation, smoking cessation advice, crucially, early recognition and care of ulcers. They empower the patient. Pharmacists are key for reviewing medications for potential vasoconstrictive effects, even over-the-counter ones, and advising on safe drug titration and managing side effects. If ulcers develop, a wound care nurse provides essential guidance on local care and dressings to promote healing and prevent infection. And very importantly, given our discussion on functional impact, occupational therapists and physiotherapists are invaluable. They can design tailored exercise programs for hand mobility and strength, provide splints or adaptive equipment, and help patients modify activities to minimize triggers and maximize function. Their role is absolutely central to improving quality of life.
It really takes a village, doesn't it?
It absolutely does. Even dietary input, perhaps exploring omega-3s or, in future, managing blood sugar, can contribute. This collaborative network ensures truly comprehensive care from prevention and early diagnosis right through to advanced intervention and long-term rehabilitation. It's this collective effort, keeping the patient's function and quality of life at the center, that makes the biggest difference in managing the complexity of RP.
So, Professor, as we wrap up, what does this all mean for our listeners today? What final provocative thought should they mull over as they reflect on this deep dive?
Well, despite how common it is and the significant impact it has, Raynaud's phenomenon is still, relatively speaking, underinvestigated. Many areas lack that really robust evidence from large randomized controlled trials. But perhaps the key provocative thought from our discussion today is this shift in understanding. That disability in RP isn't solely about the visible vascular damage. It's crucially linked to the often overlooked aspects of hand mobility and strength. This shift really opens up new and promising avenues for therapeutic and rehabilitative interventions. It urges us as medical professionals to consider a broader functional perspective in managing these patients, to think beyond just the blood vessels to the actual mechanics and capabilities of the hand.
That's a powerful point to end on. We hope this deep dive into Raynaud's phenomenon has provided valuable insights for your practice. Understanding that delicate balance between the vascular, neurological, and musculoskeletal factors is clearly key to improving outcomes.
Indeed. The multidisciplinary approach is paramount, and those emerging genetic insights offer real promise for a future of more tailored and effective treatments. Continued research and collaborative care are absolutely essential as we strive to improve the lives of individuals affected by RP.
Thank you for joining us on this deep dive, Ortho. If you found this discussion insightful, please do consider rating and sharing this deep dive with a colleague. We appreciate your continued engagement.